Hello, my name is Morten Karstel, and welcome to this extracellular matrix pharmacology symposium. This is a special day. First of all, because this is the day where we have the abstract submission deadline for the conference, the flagship event for extracellular matrix pharmacology in June. There's still a few hours to submit the last things, but we already have a record-breaking number of abstracts. We are very proud of that. There's also a record number of people that have signed up. More than 700 people have actually signed up today. And to me, it's important because extracellular matrix is central. It's central to many diseases, and that's exactly what we are going to be discussing today. We're going to be discussing how fibroblasts are important for outcome. I'm going to start showing a little bit in liver, cardiovascular, and kidney and cancer. And then Diana Julie, who is the inventor of ProC3 and have been doing fibrosis with me for more than 20 years, is going to take us a deep dive in liver fibrosis, showing you some great data. And then Nicholas, that I've been proud to work with for more than 10 years, is going to show some amazing data in solid tumors. But just reminding you that these extracellular matrix pharmacology symposia are to keep us warm between the real events and the real conferences that we are looking forward to. It's in June. I'm promising fantastic science. I'm hoping for good weather, good food, and friendship at the conference. Okay, so one of the central things we're going to be talking today is about, I think we should realize that extracellular matrix is not just something next to the disease, it is a central part of the diseases. And in order to do that, we've had a project, so it's Cecilie Bayer and Rosa, PhD students from my team that have been looking into this. Because I think it's important that we understand extracellular matrix as an overarching endotype of many chronic diseases. So we asked a group of experts, and then we looked into almost 2,000 ICD-10 codes, and then we selected the diseases that we thought were either tissue formation, fibrotic diseases, or tissue degradation diseases. And then we wanted to see what is the relationship to outcome of those, and really to emphasize that extracellular matrix is a common denominator, and we need to change that. Okay, so what Cecilia and Rosa did was really to cluster all those diseases and put them into two different boxes. And what they found out was that in total there was roughly 56% extracellular matrix as an underlying disease, and 78% as a contributing disease to death. And I think this is super important when we talk to research groups, when we talk to our pharmacology colleagues, that we need to change the matrix. And we need to change the matrix in order to prevent those organs from deteriorating, and we need to change that matrix to prevent the organ death trajectory, and that's of course what we are going to be discussing. If we take a further look into this, actually 20% live with fibrosis, and almost 40% live with at least one extracellular matrix related diseases, and then 30% live with a tissue destruction disease. Of course, some of these have both. That's why you cannot just add the percentages. So it is very clear that extracellular matrix is a big event. I should have said initially, of course, we've been very fortunate. We've been looking into this, the Danish death registers for finding these, and we're validating in the UK Biobank, and this is going to be a publication soon. So is it increasing? One would potentially think that because of COVID and because of attention to fibrosis, also because of underdiagnosing. Why would you want to diagnose a disease whether you cannot treat? And we've been seeing that IPF treatments, liver fibrosis treatments, skin fibrosis treatments are coming out. But it seems that the diagnostic, the prevalence of these extracellular matrix related diseases is more or less constant. possibly a little bit more fibrosis in men and as compared to women, and the level is relatively constant. I think these are important data for us all to reflect on. It's a big why. Why should we be doing extracellular matrix research? Well, because I want to change the trajectory of those patients that are going to die with that, and that's 58%. I'm not saying it's the same matrix in liver and in lung and in kidney and in skin, heart, in joints, but it's a central common denominator of all these different diseases, and we need to cater to that. Of course, that's what we're doing at the Extracellular Matrix Conference. I got so excited I should have said something initially like you can ask questions in the chat, and we're going to leave good time for discussions in the end, because we want the discussion and we want to ask good questions and possibly still to inspire to sessions at the Extracellular Matrix Pharmacology Conference. I got so excited because I wanted to show these data today. Publications coming out soon. Okay, so what we are going to be discussing is, of course, the extracellular matrix, and I'm starting in liver in a second. I'm mainly going to be discussing two collagens today. I'm going to be discussing type 3 collagen. Type 3 collagen is a fibrillar collagen, and it's a dangerous collagen because it is impermeable. You cannot get oxygen or blood or something like that through a type 3 collagen, a fibrillar collagen, such as type 1 collagen. It's basically locking down organs, replacing the basement membrane. Then I'm going to talk about endotrophin, type 6 collagen, and the type 6 collagen hormone, which is amazing, discovered by Philip Scherer, and later Park have identified the receptor CD44. I'm going to touch a little bit upon that. And so basically, in my world, we're looking at two different matrices. That means different things in different organs. We have the basement membrane. There are central components of the basement membrane. There's type 4 collagen, type 8 collagen. There's also fragments of the basement membrane that are super angiogenic. That means other things. And so the epithelial cells, they are smart cells. They are specialized cells. They know which way is up and down. And then you have the fibroblast at the bottom. And those fibroblasts, they are stupid and aggressive, and they need to be controlled. And if they're not controlled, then we end up having organ death trajectories that we're going to be discussing. If you want to take a deep dive in this, as we have a university-grade book that you can look further into these collagens, and I hope you're interested. And then, of course, we hope to see many of you at the Extracellular Matrix Conference. There's still a little time to submit an abstract. Okay, so of course my team is interested in biomarkers, and I'm not just interested in all biomarkers. This is a manuscript and thinking we've been evolving for the last 2 years in a group of 40 people, thinking of what are the biomarkers that are going to change the world. Because it's not about measuring more biomarkers, it's about measuring the right biomarker. So in order for me to a biomarker to be interesting, it needs to be many things at the same time. It needs to be diagnostic, elevating those that have the disease. It needs to be prognostic, elevating those that are progressing. We need to be using it as a pharmacodynamic biomarker for us later to see an effect and to possibly use that as a reasonably likely surrogate endpoint. It needs to be regulatory supported, even validated clearly at a technical level that allows us to take good decisions, and then we need to understand them. Not enough time for this today, but my favorite biomarker in the world is, you would think a collagen, but it's actually HbA1c. I mean, it's diagnostic, it's prognostic. You can have a drug approved on it. And interestingly, HbA1c hemoglobin that's glycosylated is the best biomarker for type 2 diabetes. Had we identified that on an array, that would have been a biomarker measurement for anemia that would be lower. So these small post-translational modifications, propeptide degradation fragments, I think they provide a little bit more information to modern clinical chemistry than total proteins, and that's what we're going to show you a little bit of. So initially, I'm going to show you a little bit of ProC3. And so when I say ProC3, I should just say fibroblast activation, actually. So if you have fibroblasts that gets activated, they proliferate and they make matrix. And in order for that triple helix to be put into a collagen fiber that later becomes a collagen fibril, you need to cleave off the propeptide, otherwise it doesn't fit. We actually got a letter of support from FDA as the first serological biomarker for tumor fibrosis. And Diana is going to tell you much more about liver and our launch with Roche on that. But it's a matter of fibroblast activity. And then together with Alexander Krog's group, we ask an important question for liver fibrosis. What is more important for outcome? Is it the activity of the disease, or is it the status of the disease? And I'm going to start out by being a little provocative in the end, and I think that's important for patients because we can treat and change disease activity faster than disease status. Okay, so what did we do? We had a fantastic grant, Alexander and I, from the Danish Innovation Foundation that allows us to follow almost and investigate almost 500 liver patients for 9 years. And then Stine, first author on the publication, have been analyzing the data with us and really done some fantastic work in figuring out what is most important for disease outcomes, activity or status, and it's just published in Journal of Hepatology reports. This group of patients, according to the new criteria, I've discussed that with Stine and with Alexander, they are more meta-ALD. Of course, there are ALDs, but according to the new criteria, not just ALD. So we may view them, yes, their alcohol involvement as a general population for alcohol and metabolic diseases. Okay, first thing, we measured ProC3 at baseline. And as you can see to the left, this is a super important graph. If you have a low level of fibroblast activity, there are actually no decompensations. Stine revisited the population for decompensation as defined by the Bravio 7 criteria. And I think this is super important for drug development. If there is a low activity of fibroblast, there are no outcomes. All the outcomes are in the ones with a higher level. If we compare that to the standard Kleiner fibrosis stage, meaning fibrosis evaluation by a pathologist, you can see that there are clearly differences here. If we quantify that a little bit and look at the hazard ratios and the predictors of decompensation, then the activity is roughly 50% better in predicting decompensation as compared to a standard liver biopsy. And of course, that's important for patients because prognosis is the new diagnosis. We want to know, fair enough, do I have a disease, but does it matter, and can I change it? So then Stine went on and did a really fantastic evaluation on what is the independent risk factor of fibroblast activity in addition to stage. As you can see, even in a late stage F4 population, the hazard ratio is 1.02 for outcome. This means that if you increase 1 nanogram of ProC3, then your chances of having a liver-related outcome is 2%. And of course, many treatments change these levels a lot. So it means a lot for patients if it goes down and up. Of course, if you look at the F0 to F2 stage, then activity is even more important. The hazard ratio is 5%. But even so, in all these different stages, activity is an independent predictor of risk. Just to double click on this, and this is where it becomes a little bit provocative. Then Stine put together this analysis, and it's a little complicated. If you look at the x-axis, you have Kleiner fibrosis stage. If you look at the y-axis, you have ProC3 levels, and if you look at the z-axis, you have event probability. Of course, if you have no ProC3 and if you have no Kleiner fibrosis stage, congratulations, you're not going to have an event. But if you look carefully at this, then it's actually more important to have a high level of fibrosis activity as compared to a high Kleiner fibrosis stage. In fact, if I was asked, Morten, what would you prefer, to have an F4 with a low amount of fibroblast activity or an F3 with a high amount of fibroblast activity, I would for sure choose an F4 fibrosis. I hope I'm not there yet, but I think it's really important that activity may be even more important as compared to stage because we can change activity fast. So when you see treatments that change fibroblast activity, it means immediately clinical benefit, and that's important. some of those treatments that have shown immediate clinical benefit, and Diana is going to double click and triple click on that in her presentation, is of course the first treatment approved for metabolic associated steatohepatitis, methyl was resmetirom, and the second one was semaglutide from Novo. They both change PRO-C3 fibroblast activity in two different ways, but around 20%. And of course, it's a good start, because what we want to see is biomarkers that are changing from just being a pharmacodynamic, but where the delta biomarker change is correlating to a delta outcome. That is what we need for finding new reasonably likely surrogate endpoint. And also it allows us to begin to say, what is the onset of action? How fast does patients actually benefit from this treatment? Okay. Then changing gears a little bit, endotrophin, really an exciting story. We've been following this for 10 years. I think Federica at my team, that's been the mother of this for a long time, where we've been developing different assays, originally identified by Philip Scherer. Now Park found the receptor. I'm just going to double click on that. So if we look at PRO-C6, it actually measures a signaling fragment. And I can say that now. I couldn't say that 2 weeks ago, but there's actually a signal in PRO-C6. Before we go there, then type 6 collagen is not your standard collagen. We need to call it a collagen because it has a triple helical structure, but it's assembled much differently. It's head-to-head, not aligned as normal collagens are. And then it has a feature. In the type 6 A3 chain, there's actually 12 phenylalanine A-like binding domains. It means that when fibroblasts become super activated, they can bind platelets directly. And that means that they can activate wound healing without fenvilabrine. So out of platelets, of course, come TGF-beta, PDGF, the biggest sources of these, and causes an acute wound healing and fibrogenesis. So type 6 collagen is dangerous in itself. Now it's even more dangerous because of the release of endotrophin that's doing important things that I'll come back to in a second. So we've been investigating this for a long time, initially in a fantastic collaboration with BMS and UPenn. We were asked, can we do a better biomarker than NT-proBNP, which is, by the way, the best biomarker for heart failure until now? And we saw that so this is tertiles. It's in the New England Journal of Medicine publication, unfortunately my only New England Journal of Medicine. But in the highest tertile, 70% was dead after 4 years. It must mean that fibroblast activation is an endotype. Then Federica and team went on and measured 15,000 different samples in different studies, so kidney cancer, diabetes, respiratory, others, and the overall risk for having an outcome was 2. Meaning if you double the rate or double the level of endotrophin, you have a twice the chance of having an outcome. So endotrophin is important. Then Alexander Rehse, former PhD student and later research scientist in the group, did a little bit different calculation. I think this is interesting. Looking at quite a few studies, we saw that if you increased in the PRO-C6 level by 1 nanogram per ml, your chances of mortality increased by roughly 10%. Now, that's something we can use when we talk about clinical benefit to patients, changing biomarkers fast that are related to outcome. And then talking about the epitope. So the PRO-C6 epitope, endotrophin here, that was a New England Journal of Medicine publication, whereas the same protein measured in a different way with degradation that is important for autoimmune diseases, there was no difference. So when we advance in clinical chemistry, I think we really need to take care and look into the epitope, which is, by the way, also a prerequisite under the CLSI guidelines for FDA validations. So important stuff. We developed a sandwich assay, and the sandwich assay is currently being put on the Roche platform. It's possibly a little bit better than PRO-C6. It's measuring the 77 amino acid peptide. I would say PRO-C6 is measuring all the peptides, all fragments of endotrophin and thereof, and the sandwich is just endotrophin. And Federica has done so much work. There's not enough time for that. 25,000 patients with an overall hazard ratio of roughly 1.9 when we put all these together. So if your level of PRO-C6 is high, you may die. Okay, then there was this amazing publication publication from the Park group. And I'm just going to show you a little bit of that, because I spent some years of my life looking for the receptor and failed. And so, of course, it's always with mixed feelings that when you see somebody doing so nice research, you want to be part of it and you are glad that it's out there. But also, I hope to have found the receptor myself. Possibly there are other receptors, let's see. Anyway, endotrophin binds to CD44, and the group really did wonderful work. They did what they're supposed to do. They do co-IP one way, the other way. They do different proximity assays. They do mapping of the interaction. So there's no doubt that endotrophin is a receptor, or CD44 is the receptor for endotrophin. Could there be more receptors? There could be. I think what's interesting is that endotrophin is actually activating STAT3 through the CD44 pathway. It's a biased pathway, and there's actually some drug under development for interaction with CD44, and there's also STAT3 drugs under development. Possibly, this would be a very interesting place for looking at endotrophin. The moneymaker in this study is this one. So what you see is it's a high-fat diet mouse model that is fed with a toxin that gives it liver cancer. And in the first D graph here, the gray bar is tumor number, the pink bar is in the endotrophin null mutation, and the other pink bar is the CD44 null mutation. And so if you had a double null mutation, these animals did not develop hepatocellular carcinomas. I think this is very interesting because it's linking an epithelial. So the CD44 is produced in the cells around the basement membrane in the epithelial cells. And when they become super activated by endotrophin, there's a lot of data here suggesting that there is EMT, or at least that there's transition into a fibroblast-like phenotype. They proliferate, they produce matrix. From matrix, we go to hepatocellular carcinoma. This is a liver model, meaning it's important for liver. We see endotrophin elevated in many other things, so possibly this could be a link that is general from transitioning from fibrosis to cancer. More data on that. I cannot say endotrophin without also mentioning kidney. This is two big kidney studies that Frederica has been working with. So roughly 1,500 patients. They are high-risk patients, and they have multi-comorbidities here. And just showing you, if we measured in serum, this is a combined kidney endpoint. There's just one measurement at baseline. There's a very nice dose response in both these studies that are more or less the same for developing a chronic kidney disease in these ones. And actually in the high ones, again, it's tertiles, the risk is there's more than 75% that actually developed a combined kidney endpoint in these. And it's more or less the same in the two studies. So clearly endotrophin driving disease. Of course, Frederica has done an amazing job with her team in combining many studies and looking at the overall risk. This is 20,000 patients. We're gathering more. So the combined evidence that endotrophin is actually an outcome biomarker for multiple diseases is overwhelming. It's actually a better outcome predicting biomarker as compared to CRP or cholesterol. So I think it's just saying that fibroblast activity is important and that we need to control those fibroblast activities. ProC3 is one of those, type 3 coded information is one of those, and type 6 coded information is another one of those. Last two slides before Diana is going to take you to a deep dive in liver is, if you were not afraid of fibroblast before, I want to make you really afraid of fibroblast now. So of course, cancer, and Nicholas and his team have been looking into this for quite some time. Of course, cancer is a super fibrotic disease, including pancreatic cancer. And not enough time for that today, but is fibroblast dangerous because they block penetrance of drugs or because they're doing something for themselves? I think the jury is out there. I think it could be more things. We actually got a letter of support for this. I just want to show you. So this is one baseline measurement. It's the high levels of ProC3, and this is in tertile as compared to the low levels. It's the three leading immuno-oncology drugs. These are all metastatic melanoma patients, and what you can see is If you have a low level of ProC3, in particular in the center here, congratulations, you are going to have a good benefit of the compound. However, if you have a high level of fibroblast activity, you're most likely going to die. That means, one, we need to find something for those patients that have high levels of ProC3. But it also means that this can really be good, or a potential way of finding superior responders and for benefiting those patients. If we put that in a little bit different way, then in study number 1, the median overall survival was increased by 2-fold. In the middle study, it was 7-fold, and in the last study, it was not calculated because the ones with low levels actually did not die. That's how important fibroblast activity is. Then the question is, if we change it, do they live longer? And Nicholas just had these data together with a collaborator. So they had a baseline sample of these cancer patients. They had after 1 month of treatment, and then he asked a simple question: what happens if ProC3 fibroblast activity increase, blue ones, or decrease? Very clear that there's survival increase associated with controlling your fibroblast. And if you look at the 6-month overall survival ratio, it's actually 3-fold. That the patients with a decrease in fibroblast activity can show. Last thing I just want to emphasize, it's teamwork. I showed tons of Federica data here that have been doing all this, and I showed you a lot of Diana's data and a little bit of Nicholas' data. And now Diana is going to be taking over. I'm going to try to see if I can stop sharing here and possibly see if there's a few questions in the chat before we move on. There are tons of questions in the chat. I think we are best left off with Diana. If you continue, then I'm going to collect the best questions here, and then after Diana's presentation, then I will be taking questions to both Diana and my presentation before we move on to the oncology. Diana, I can't wait to hear what you're going to say. I'm going to leave. Yeah.
Fantastic. So I'm just finding a pointer. So nice to be on this webinar and hopefully having great questions after this presentation. So I'll be discussing, as Morten mentioned, how we can use different biomarkers, non-invasive based biomarkers for understanding fibrosis, especially fibrosis activity, remodeling overall, and outcome. And I'll pay especially attention to what we call the FIB-NIT panel, which stands for the Fibrosis Non-Invasive Test Panel. And I'll come back to what this means. I'll also touch upon a newer concept in liver, which is this hot and cold fibrosis, and how potentially we should monitor this in liver patients. So I'll start out with this figure. So we think it's very important to understand the balance for fibrogenesis and fibrolysis. I think more and more attention is coming to this topic in the space overall, and we have been discussing this actually for many years, and we've done this in other indications as well. So in a balanced remodeling in healthy situation, you will have a balance between fibrogenesis and fibrolysis measured by ProC3 and CTX3. And these are both measured in blood samples. Then in the case of disease that skews towards accumulation of fibrosis in a given tissue or organ, such as in liver, then you have accumulation of extracellular matrix. This actually means that you have more fibrogenesis compared to fibrolysis. And this is really what we want to change, and then change it to a more fibrolytic type of an endotype. So this means that you, ideally with a given intervention, you would like to change the balance to have more fibrolysis compared to fibrogenesis. So really changing the balance between these two processes. And what also is to be noted is what we see in patients with fibrotic disease is that both fibrogenesis and fibrolysis is increased, whereas when we see intervention, then actually both are decreased, but what we see is that CTX3 is reduced, but it exceeds the ProC3 level. So really it's all about the balance. And that's what is going to link me also to this FibNRT panel, which is part of the Nordic protein fingerprint technology. It includes the ProC3 biomarker that is quite well known in the liver field for fibrogenesis. So it's really originating from activated fibroblast. Excuse me. Then we have CTX3 that I also just mentioned. It's a marker of fibrolysis. And our origin cell-based is really macrophages, because this fragment is released by MMP activity. Then finally, we have the ProC6 biomarker that Morten also just mentioned quite extensively. It's a marker of outcome, as you just saw, and it's also originating among others from activated fibroblasts. So we think it's important to monitor these to really understand a given mode of action of an intervention that is investigated. I'll start out with some data on ProC3. Again, I'll be a bit quick with some of the slides because Morten already showed these. So first of all, I would like just to introduce you to the ADAPT score. It's a score that we published in hepatology in 2019, so quite some years ago. It includes age, diabetes status, ProC3 and platelet counts. And this is a score that was developed to really understand the stage of fibrosis in patients with NAFLD/MASLD. And this score can now actually be measured on the Rose-Cobas system. This was recently, or last year, it was CE marked and has IVD approval in Europe for finding a significant and advanced fibrosis, as well as cirrhosis in patients with MASLD. So this is, of course, very important that that you can actually measure ProC3 on this Cobas system, so getting closer really to patients. And also this ADAPT score has been investigated in several cohorts. I'll just show you one example here, which came out from the Litmus consortium, which we were part of. This is totally around 1,000 patients, biopsy-confirmed MASLD, TetraCare center patients. And here there was head-to-head comparison among different non-invasive tests, single markers and scores. And actually what we saw here in this meta cohort, as it was called, the first cohort that was analyzed, published in 2023, then we saw that ADAPT actually outperformed FIB4 for finding a patient with advanced liver fibrosis. And also soma signal was one of the better performing biomarkers. Also quite some years ago, we have actually shown that understanding fibroblast activity by measuring ProC3 actually reflects histological changes in liver fibrosis. So this is a study we did with Dr. Ken Kusi some years ago. This was patients with type 2 diabetes that were treated with vitamin E or pioglitazone or placebo. They were pooled in this analysis, and it was 18 months of therapy. And what you clearly see here is, if you look at the change in ProC3 over this time period of 18 months compared to patients that improved or didn't change or worsened in fibrosis stage, we actually saw that those who decreased in ProC3 were the ones that had improvement in liver fibrosis compared to no change and worsening. And this actually equals the percentage that you see here. It's around 18 to 25% reduction in ProC3 that equals an improvement in fibrosis, at least in this cohort of type 2 diabetes and following them for 18 months. I just wanted to highlight this again. This is very important data that Morten just flagged. This is showing that ProC3 is indeed prognostic for risk of decompensation in patients with MET-ALD or SLD in general, steatotic liver disease, and it has a high hazard ratio of finding those patients that will have decompensation. And this is full spectrum fibrosis, I should say, so it's not only cirrhosis, it's actually full spectrum where we see events occurring in also in earlier stage patients. But clearly you can nicely separate patients using a baseline measure of fibroblast activity by ProC3. We've actually also shown something similar in cirrhotic patients, that ProC3 is prognostic for the risk of liver outcomes in patients with cirrhosis, which we published together with Neil Guha and others in 2023. And here you see also very nice separation between the high and the low baseline ProC3 levels. And then I'll jump in to the pharmacodynamic evaluation on usage of ProC3. So here again, Morten also mentioned these are two phase 3 studies, one from Madrigal and one from Novo, so semaglutide and resmetirom here. They have both shown that they can actually over time reduce ProC3. So This indicates that they're actually reducing fibroblast activity based on the PRO-C3 measurements, which of course is positive, and also if they have approval. At least Madrigal was the first drug to be approved in EMA and also US, and also the Novo drug semaglutide is obtaining approvals as we speak. Also in phase 2 studies with efruxifermin by Akero, survodutide by Boehringer Ingelheim, tirzepatide by Eli Lilly, they have all shown that they can reduce the fibroblast activity by measuring the PRO-C3 and in these phase 2 studies. So actually PRO-C3 is used substantially and part of the FibNIT panel. Then recently, last year, there was this nice publication from Nitze et al. Showing that semaglutide, of course being a GLP-1 therapy in the phase 2b MASH study, they showed that actually over time, in phase 3 it was only one time point, but over time in the phase 2 study, they looked at baseline and then week 28, 52 and 72. There was a clear separation of PRO-C3 already at the week 28, and then this was sustained throughout the study. I'm suspecting that this separation would probably potentially be seen earlier on, but clearly there was a very nice separation between semaglutide-treated patients and placebo-treated patients. This was also seen when they looked at the ADAPT score. There was also other markers showing effects like hepatic fat by CAP, apoptosis by CK18 fragments, fibrosis stagings, FIB4, liver stiffness measure, LFAS, NIS4, and MASAF. And you can see it's quite different how good the separation was at week 28, but for clearly semaglutide had a positive effect on fibroblast activity. Then in cirrhosis, patients, in this case compensated cirrhosis, Madrigal have tested also the resmetirom intervention in patients followed up for 2 years, and also shown that they actually in this type of population, PRO-C3 can be reduced by up to 40% after 2 years of therapy, and also corresponding to again apoptosis and liver stiffness measure by BCT, which also had the same type of trends, showing that there's a positive effect by resmetirom in cirrhotic patients. Also recently, Akero have shown in the Symmetry trial, also a cirrhotic population of MASH, phase 2b, that actually PRO-C3 can be substantially modified and decreased with 2 different doses of efruxifermin compared to placebo. So we know that fibroblast activity can indeed be reduced in patients with cirrhosis, at least decompensated cirrhosis, and time will tell how decompensated cirrhosis will look. And then I'll move forward to the CTX3, the fibrolysis biomarker, and some of the data here. So I'll just give you a bit of background first of the CTX3. So it really originates from degraded extracellular matrix. So type 3 collagen has to be incorporated, or it has to be produced. P3MP has to be released. That's where we're measuring PRO-C3. And then when the type 3 collagen is matured and laid into the tissue, then later you will have degradation of that matrix. And we showed it actually in a fibroblast or hepatic stellar cell model called the SCAR-NAJAR, where we measure PRO-C3 over time up to day 12. When we activate fibroblasts by TGF-beta compared to no treatment, you can clearly see PRO-C3 is released to the conditioned medium, but CTX3 is not, because it requires MMP activity. So we do not see this fragment in the conditioned medium. But actually then when we take that matrix that is produced by these fibroblasts or hepatic stellar cells that have been activated and cleave this in vitro by MP9 and 13 compared to pepsin treatment, then we can actually release CTX3 from this matrix, showing again it is actually a fragment coming out of a degradation of matrix that is linked to fibroblast. This is also data published quite some years ago. These are patients with hepatitis C followed for 1 year, and then had biopsy at baseline and week 52. And then they were stratified into having regressive, stable, progressive endotype. We already knew that PRO-C3 was elevated in progressive patients. So we wanted to understand CTX3 for fibrolysis. How does this look in these patients? Clearly, it was seen that those who regressed, that CTX3 was increased at baseline compared to stable and progressive patients. As I mentioned, we knew PRO-C3 was just opposite. And then when we look at the balance between fibrolysis and fibrogenesis by CTX3 and PRO-C3, we clearly couldn't stratify these patients into these 3 different endotypes, which of course is very important in understanding patients' trajectories and risks. Recently, Andresa from my team, Andresa Savatsky, she presented at AASLD last year how measuring ProC3 and CTX3 together actually increased the prognostic evaluation of patients with steatotic liver disease, in this case for those who are at risk of having liver decompensation. Here we see CTX3, that if you measure CTX3 at baseline, having this cutoff, which is a non-official cutoff for now, 13.5, we could see those above the cutoff at baseline had a hazard ratio of 2.6 for having decompensation compared to those at the lower CTX3 levels, so lower fibrolysis levels. So it was in this case bad to have high levels of CTX3. And that's, as I mentioned initially, that we have the high remodeling status ongoing. So we have both high fibrogenesis and fibrolysis ongoing in those patients who are progressing. Then when we looked at ProC3 together with the CTX3, we saw that those patients who had both high ProC3 and CTX3, they had a hazard ratio of more than 18 of progressing to decompensation when they had these levels at baseline. So this is the blue graph that you see here. We also saw that if you have the high fibrogenesis, this really also drives disease, and having the low CTX3, then you have a hazard ratio of 7, but having both really was where you saw the higher hazard ratio. Akero have shown with their efruxifermin, FGF21, that they can actually significantly reduce the ProC3 and CTX3 ratio. This was presented at EASL 2024 by Eric Tillman. They showed with 2 different doses of efruxifermin that they can reduce the ratio compared to placebo, and even more in those patients who at baseline are above the median. So these who have more disease activity, they respond better to therapy. And actually it tracked very nicely with the biopsy-proven liver fibrosis by the climate staging. And here you see the ProC3, CTX3 ratio change from baseline to week 24, and then the change in fibrosis stage from baseline to week 96. Then you saw those who declined in the ratio actually were the ones that regressed in fibrosis stage, which is what we want to see in patients to regress fibrosis. So it's beneficial, according to the data we have now, to change the ProC3 CTX3 ratio. Boston Pharma have in their phase 2 study shown also they can reduce the ProC3 and CTX3 ratio. This is placebo compared to 30 milligram of efruxifermin, again showing that they can beneficially reduce or change the balance between fibrogenesis and fibrolysis. Then at AASLD last year, there was a late breaker oral and also a poster showing that, first of all, with this GLP-1 glucagon mode of action, the ProC3 can be reduced in 2 different doses compared to placebo. But also, again, ProC3, or not again, but this was because this is another mode of action, ProC3 CTX3 ratio could be reduced compared to placebo, and even placebo treated patients progressed in this ratio. And also the ProC6 marker that Morten mentioned a couple of times with the cardiovascular risk, especially, but in general outcome biomarker, this could also be reduced by this mode of action. So we think this is very important to really understand these different aspects of both fibrogenesis and fibrolysis and risk of outcome, especially the cardiovascular risk in these type of patients with MASH. Then I'll go to the last biomarker of the FibNRT panel, ProC6. This is endotrophin. I don't need to introduce so much. Morten did this very well. It's a marker that is very important to understand for. It's important to understand because it's pro-inflammatory, pro-angiogenic, pro-fibrotic, pro-steatotic, pro-diabetic. It's a very actually bad fragment to have high levels of, so it's very important to monitor this and also treat potentially. Again, it's been repeated in 6 HFpEF cohorts by Dr. Federica Genovese and UPenn as well as BMS, that it's bad to have high levels of endotrophin. This leads to a higher risk of cardiovascular endpoints. Therefore, we actually looked in the patient population, again, the SLD population recruited as ALD patients. It's more than 450 patients where we looked at the cardiovascular risk together with the Odense team by Alexander Krag, Maja Thiele, and in this case, it was Ida Spetsberg who presented this. They collected the number of cardiovascular events in this population and then related PRO-C6 at baseline to these events and showed that actually having high levels and intermediate levels of PRO-C6, these two levels, actually was related to a higher cumulative incidence of cardiovascular events. So again, in this liver-related population, we also showed that there's a link between PRO-C6 measuring endotrophin and cardiovascular risk. ECERO have shown that efruxifermin has effect on PRO-C6, and as I just showed before, also the autoimmune pemvidutide also has effects, positive effects reducing PRO-C6, which is of course very nice to see that some of the upcoming drugs potentially have anti-cardiovascular effects and outcome risk effects, which is ideally what we want to reverse fibrosis and then lower the risk of events. So with that, I will end the FibNRT highlights. We have tons of more data than what I just showed. Then I have a few minutes left to just introduce you to the hot and cold fibrosis concept, which is quite new in liver. It's of course been discussed for quite some years in the space of oncology. But I think, and we think at Nordic Bioscience, it's quite important to understand this status also in patients with chronic liver disease. Because it's important to understand the immune status in disease, and we should also monitor this. And not all inflammation is bad. We need inflammation really to degrade the tissue that has been generated. So probably there's a time where inflammation is bad, and then a later time point where you actually need inflammation to have this continuous repair and resolution ongoing. So I think this is important to understand the status of patients in relation to this hot and cold fibrosis. And we have very nice data coming up at some of the upcoming conferences. So in the case of hot fibrosis, we have active immune cell infiltration and inflammation. We have cells coming in that are resolving, for example, the fibrotic tissue in the liver. And then vice versa in cold, then there's exclusion of the immune cells. It's a desert type of tissue, and there's no cells really that can resolve this fibrotic tissue. So of course, this becomes a problem for patients if they have substantial amount of liver fibrosis and there's no cells to really remove this tissue. And of course, there's also other implications. Again, I'm running out of time, so I'll go a bit quick through this. So I think it's important to really understand how cells can be used as source of biomarkers and their effects on the extracellular matrix. So I'll start out with the T-cell activity biomarker actually developed by Nicholas, who's also on the call in his team. So this is a type 4 collagen degraded by granzyme B. So it's really related to the T-cell activation, because when T-cells are activated, they produce granzyme B, and they do this during invasion of basement membrane where you have a lot of type 4 collagen. So therefore, we actually have release of this C4G biomarker to the blood circulation. So in this way, when we measure C4G, we can understand T-cell activity. We have our macrophage activity biomarker, ECM, which is CYP-related vimentin that is MMP degraded. Again, it can be picked up in circulation and reflects the macrophage activity. And we've done different cell models in our immunology team to show that there's a link between these two. Finally, we have CPA9-HNE as part of our hot and cold fibrosis panel for neutrophil activity. So it's calprotectin that is degraded by human neutrophil elastase. This is something that is produced during mitosis and inflammation. Again, in SLD patients from the FLASH team in Odense, Andressa has shown that, first of all, measuring CPA9-HNE at baseline and measuring neutrophil activity, those patients who have lower levels at baseline actually are the ones that have a lower survival probability. So here it seems to be good to have high levels of neutrophil activity, linking to the fact that it's good to have some activity of the immune cells in these type of patients. And then if you combine the PRO-C3 and the CPA9-HNE, so fibrogenesis, and the cold/hot fibrosis aspect, then if you have high PRO-C3 and high CPA9-HNE, then you have a hazard ratio of 4 for progressing into decompensation, whereas high PRO-C3 and low CPA9-HNE has a ratio of 2. And then actually, if you have a low PRO-C3 and high CPA9-HNE, you are a bit protected for having decompensation. So this is something we're investigating a bit more, this concept of hot and cold fibrosis. We've seen something similar with the C4G biomarker for all-cause mortality, showing that the understanding both PRO-C3 and C4G then you can increase the hazard ratio for finding those patients who are progressing into a more severe stage of disease in general. Then I have 2 more slides. This is just some of the data we have generated recently for this hot and cold type of biomarkers. And this is in patients with cirrhosis. We did this together with Søren Møller from Hvidovre Hospital here in Denmark. Or actually Emilie Skovgaard, who is a former PhD student of mine, she looked at CPA9 H&E for neutrophil activity, ECM for macrophage activity in these patients and stratified them according to Child-Pugh score and to portal hypertension or HVPG. And what she saw actually what was with increasing Child-Pugh score and with increasing portal hypertension or HVPG, then actually neutrophil activity went down and also macrophage activity went down. So it seems like with increasing severity, then you lose, or the capacity to generate this immune response actually is lost. And quite interestingly, when we measured CRP, we saw opposite, this goes up. So it seems like there is a response by producing CRP. So the response to ask for this immune response is there, but it's not really arriving in the tissue. It seems like when we measure these cell-based biomarkers that have these effects on matrix. Then finally, we saw opposite with the fibrogenesis biomarker, cellular stress, apoptosis measured by ProC3, GDF15, and CK18M30. Here we saw the classical thing that they increase with increasing severity, both for Child-Pugh score and portal hypertension. So this led us to this schematic that really we think in case of cirrhosis heterogeneity, we could understand this potentially better with some of these biomarkers. We have fibrogenesis, clearly this increases with increasing Child-Pugh score. We have more and more cold fibrosis ongoing with increasing Child-Pugh score, systemic inflammation increases, and apoptosis also increases. So we think it's important to really understand this concept in the future. And with that, I'm happy to take questions later and then leave the floor for Nicholas and Morten.
Thank you, Diana. We have tons of questions and tons of good questions. Let me start with first ones for Khurram. How often should we be measuring these fibrosis activity biomarkers in F4 settings and possibly F3 settings?
So I guess the question is for me. So of course, ProC3 is used substantially in different clinical trials, and it's mostly been in F2 and F3 populations. Now we're seeing more and more data coming out in cirrhotic populations. So I think we need to see some of the data coming up with, for example, efruxifermin and resmetirom in cirrhosis, and also other interventions in cirrhotic populations. So I think Akero has shown that they could reduce ProC3 significantly at week 36, and actually that reduction was very substantial. It was 40% reduction. So I think we would see some effects on earlier time points, but I think we need to show that data. But our expectation is that if you have a mode of action that hits that fibroblast activity, you would see hopefully a fairly early response to guide the drug development.
I completely agree. I think there's an additional point to this, that the placebo group in phase 3 patients is surprisingly stable. So unless you start to not eat or you have intervention, then the stability of fibroblast activity, unfortunately, is relatively clear. So for those patients to change the trajectory, we need either an intervention or a clear change in life in lifestyle. There are many good questions. One of my favorite ones here that I have no idea, from Joel: how do the endotrophin, CD44, hyaluronic acid pathway compare? And what is the affinity of endotrophin to the CD44 receptor? We don't know. I think these are clearly some of the questions, because I have a feeling that there may be more receptors coming, and the affinity of the individual receptors, of course, is super interesting to further investigate. Then now, Nicholas, that you are on the floor, why did we show melanoma when some would say melanoma is not a fibrotic cancer?
It's true it's not your first go-to for finding a fibrotic tumor, but in the metastatic setting, when we have looked in many different cohorts, we do see at least approximately 1/3 of patients presenting with fibrotic activity, and those do worse than those with low levels. So yeah, I think it's probably an overlooked phenomenon, and based on our data, definitely present in a subgroup of patients.
Then there's another question, possibly Diana knows this. Any data in evaluating fibrosis, formation, degradation biomarkers in acute and chronic graft versus host disease, possibly liver transplant or kidney transplant?
We have done previously data on protocol in the transplantation. Fortunately, for now, we have not looked at the ratio, but I think it's a very important aspect to understand. We did actually do something, it's not a graft, or not transplantation, but we did something in patients that are very advanced, patients with liver disease that are undergoing TIPS insertion. Here we saw that actually the ratio still was prognostic for those who survived longer. So actually, if you reduce that ratio, then survival was better in those that had reduction in that ratio. Again, it's not a transplantation, but at least close to these type of patients, patients who have very high port hypertension, which is relieved by TIPS insertion.
If Frederica was listening, she would say that PRO-C6 is the best biomarker for predicting progression to end-stage renal disease. And he has done one study in seeing if baseline levels at PRO-C6 are actually predictive of renal transplant failure or how they progress. And it was actually amazing to see how the fibrogenesis and wound healing biomarkers were associated with that. There are many things we can add to that.
Can I just add, we also have other markers that we have looked into in relation to liver transplantation, like looking also at basement membrane biomarkers, because if you have a healthy liver, then it's maybe more sinusoidal type of fibrosis initially. We've done a few publications actually recently, and an older one showing that also some other markers can be evaluated for this. But for the more severe stage, then I truly think that the type 3 biomarkers and the ratio would be interesting to understand.
I agree. So there's one here from Oreste, Nicholas, before you start your presentation. Any data on PRO-C6 levels in breast cancer and possibly in other types of cancer?
Other types of cancer, yes, and I'll show you a little bit of that data also. Circling back to endotrophin, of course. In breast cancer, ongoing as we speak, actually, to evaluate that.
Why don't you, Nicholas? Frederica is listening, and PRO-C6 was also predicted for T-cell mediated rejection in kidney transplant. Glenn is asking, any data in lung diseases, IPF? Tons. Will have a IPF seminar coming up. If it's Glenn Rosen, then fantastic to hear from you. It's been a while. Nicholas, I think you need to be dazzling us with some tumor fibrosis data, and then we'll revisit questions in a second.
Thanks. So let me jump into it. I'll talk about circulating collagen fragments, basically as functional readouts of cancer-associated fibroblasts, and how we can use that in the clinical setting. Just very briefly on the background, if you're from outside the oncology space, what are cancer-associated fibroblasts doing there? Well, of course, they are building up the desmoplastic tissue, so deposition in collagen and remodeling of extracellular matrix, providing increased tissue stiffness and hypoxia, so that gives a pro-thrombogenic microenvironment, but it's also generating a barrier for treatments to reach the tumor nest. So essentially, these processes are related to tumor progression, but also therapy resistance. That's a dysplasia, but fibroblasts also affecting angiogenesis, and they are affecting the availability or the possibility of immune cells to reach the tumor sites, but it's also impacting the activity of the immune cells. These fibroblasts have quite some roles in the tumor microenvironment. And we have spent a lot of time in the cancer space looking into the heterogeneity of fibroblast, cancer-associated fibroblasts. These are, of course, very plastic cells, but they are also very heterogeneous. They span from being tumor promoting to being more tumor restraining. This is very time and context dependent, and as I mentioned, this is also not something that is a defined endpoint. They can change in their endotype and phenotype depending on context. In recent times, we have been grouping fibroblasts into whether they were inflammatory fibroblasts, ICAFs, whether they were myofibroblastic, or whether they were antigen presenting. So this is one way of grouping cancer-associated fibroblasts that has been used quite a lot out there. So the question then is, how do we translate this cancer-associated fibroblast biology into clinically actionable biomarkers? We can, of course, look at service markers like FAB and alpha SMA and other things that are defining the state of the fibroblast, if you like. But probably we should also look at the functional impact on the tissue, which is very much related to the role that the fibroblasts play, which is fibrosis and extracellular matrix remodeling. This is, of course, where we come in with our technology, looking at collagens and other ECM proteins. And it happens to be so that in solid tumors, at least for patients with high degree of dysplasia, not only is the collagen disorganized and completely changing composition, it is also being remodeled with a very high rate. So the turnover of all these proteins is just insanely elevated compared to healthy tissue. And that generates many different types of collagen fragments that we can then measure non-invasively, as we do with PRO-C3 and PRO-C6. And I will show you some of that data and linking that to fibroblast activities. Of course, that can give us some insight into what is going on in the tumor microenvironment, and we can hopefully use it to stratify patients better at baseline, but also look into on-treatment effects. So to set the scene, I'm showing you here 6 patients with pancreas cancer, to just as an example of how extracellular matrix remodeling actually reflects the disease activity that's ongoing in solid tumors. So we have 3 patients here with stable disease in orange, and we have 3 patients with progressive disease. If patients have progressive disease, their collagen remodeling is also very stable over time. They remain very flat, these curves here. As soon as they have progressive disease, we do see an early and substantial increase in the collagen turnover. So the more active disease, the more progressive disease, the more your tissue remodeling and collagen remodeling increases. So this is to link extracellular matrix remodeling to the disease activity. Of course, if you can somehow modulate this, bring them back to normal or lower in levels, that should also be beneficial, as I will come back to. So what we see in general terms with our collagen remodeling biomarkers, especially related to fibrosis, is that throughout these different flavors of collagen fragments that we can measure, if biomarker levels are high at baseline, patients have substantially shorter overall survival than if they have low biomarker levels. This basically goes for across indications and for many different modalities, that this is a clear prognostic indicator. We already talked a lot about PRO-C3, which we of course adapted from the liver fibrosis space and took into the oncology to have a very robust biomarker to reflect fibroblast activation there. As already alluded to, this PRO-C3 measures the propeptide released from newly synthesized collagen triple helices that are then subsequently built into the fibers in the tissue. And we have this letter of support from the FDA for clinical trial enrichment or for risk stratifications of patients with solid tumors as such, because we have data spanning 20, not more, different indications. So show you a little bit of data. Let's start with the metastatic melanoma that has already been discussed. Not your typical fibrotic disease. We see, regardless that there is approximately 1/3 of patients that have high PRO-C3 levels at baseline, and these do substantially worse than those with low PRO-C3 levels. I think melanoma is a nice model for immunotherapies, because we actually have patients that are truly benefiting. And here you can see that it's actually patients with a low fibrotic burden that are those particular patients benefiting the most. And then, as discussed, we need to do something with those that have high PRO-C3. To give you the cellular link, also here we are looking in an in vitro culture of Guysian fibroblasts from a benign pancreas donor that produce fairly low levels of PRO-C3, at least compared to a fibroblast coming from a cancer patient. And we can play around with the TGF-beta pathway to modulate PRO-C3 levels. Of course, it's a very pro-fibrotic cytokine. Eventually, what we measure in terms of PRO-C3 being secreted out of fibroblast correlates very nicely to the net collagen deposition quantified by zero-red staining. So this is an early surrogate of fibrogenesis and fibroblast activity. Interestingly, when we take out more than just fibroblasts from one donor, but also take here 4 different donors of fibroblasts, of cancer-associated fibroblasts, they're all defined by the same status, the same surface markers you can see here. And look at their fibrotic activity in this fibroblast model system we have, then we can see that there are 2 of these fibroblasts that are intrinsically very active, produce very high levels of PRO-C3. We can only push the system a little bit more with TGF-beta because they're probably already running full speed. But then we have 2 other fibroblasts here, also from cancer patients with the same markers, that are much less active in terms of producing PRO-C3, and relative to their baseline levels, we can push that system much more with TGF-beta. So these are very different fibroblast subtypes in terms of their fibrotic activity. Again, that's important because the fibrotic activity is clearly prognostic in the clinical setting. So moving beyond just melanoma, showing you some more classic desmoplastic or fibrotic tumor types. We have here pancreas cancer, we have hepatocellular carcinoma, and we have colorectal cancer, where we measured PRO-C3. You can see the different scatter plots here on top. You can see also that hepatocellular carcinoma patients actually have higher levels than cirrhotic patients. When we look at the prognostic component, if patients have high levels of PRO-C3 at baseline, they live much shorter than if they have low PRO-C3 levels. So this is a clear prognostic signature of fibroblast activities matter for cancer outcomes. So then the question becomes, is this just something that you are measuring that is part of your classical risk stratification tools that you're already providing, or you're bringing something in additional to what's already being measured? And luckily the answer is the latter. We are actually independent prognostically for predicting outcome in solid tumors. One example here from the pancreas cancer study on patients treated with chemotherapy. When we adjust for age, when we adjust for number of metastatic sites, stage of disease, CA99 and the formal status, a lot of fairly strong risk factors, PRO-C3 remains independent for predicting outcomes. So it's a unique biology that we thought of bring to the table, highlighting the importance of the fibroblast. You could also ask, and this is from cholangiocarcinoma as an example, also one of your more fibrotic tumor types. We have the survival data on the left, but then is this only found in the advanced disease stage, or is it also found in earlier disease stages? And as you can see from this very nice scatter plot from different stages of cholangiocarcinoma patients. Compared to the benign condition here, we actually see that throughout resectable, locally advanced, and metastatic patients, there are patients with sky-high levels of PRO-C3. So it's also independent of the stage and the burden of the disease. Then Morten already showed you these data. I'll just recap. So we are now beginning to have accumulating data where some patients happen to be so lucky that they also have a reduction in PRO-C3 on treatment. So here we stratified in pancreas cancer as to whether patients were decreasing or increasing in PRO-C3 levels already after one cycle of treatment. This treatment was given to refractory metastatic pancreas cancer patients, and they were treated with EP, with Nivo, and with radiotherapy. So pretty harsh treatment here, of course. You can clearly see there's actually almost a threefold difference in the median overall survival time if we are comparing those that are decreasing in PRO-C3 compared to those that are not. You can also look at it differently by looking at the 6 months overall survival time, where that threefold the number of patients still alive if they had a decrease in PRO-C3 compared to if not. So clearly PRO-C3 is an important biomarker for solid tumors, and it's prognostic, and it can hopefully be pharmacodynamically modulated because that also seems to be beneficial for patients. But the cool thing about Nordic technology is, of course, that we are not just measuring type 3 collagen, we are measuring different flavors of type 3 collagen. And each of these collagen fragments, that gives us a little bit of a unique information. So with PRO-C3, for example, we can measure formation of new type 3 collagen from fibroblast. With this C3F biomarker, we can measure the remodeling of the type 3 collagen due to the fact that positive fibroblasts are actually remodeling their collagen type 3 in the vicinity of themselves by having this fibroblast activity protein degrading type 3 collagen. So we have a biomarker C3F to quantify that. So formation and degradation is one way of exploring fibroblast activity. When we look at these data in the context of outcome for patients, we have this study from pancreas cancer patients. We just validated these, and that will be presented in summertime in June in Copenhagen. But another story here, we basically show both of these biomarkers measured at baseline are prognostic for outcome. So if you have high PRO-C3 and if you have high C3F, both are bad for survival. We can look at the correlation between the two and see that they are different. So it's different pathological processes possibly that we are looking into, which then led us to combine these two biomarkers and can actually see clear complementary value. So here we are looking at those that are low in both PRO-C3 and C3F and are combining that or comparing that to those that are high in either or both. And then we actually end up with a hazard ratio of 0.35, a 65% reduced risk of dying if you have low, let's call it fibrotic activity compared to high fibrotic activity. And here's another important mentioning. It's not just the overall survival, it's actually also on the clinical response rate, on the RECIST criteria for these patients. If they have an objective response or if they have low fibrosis, they have much higher objective response compared to the high fibrotic activity. So this the functionality on the collagen remodeling of the fibroblast can really provide some clinical meaningful insights. Then we took it a step further and asked the question, beyond PRO-C3 or beyond type 3 collagen, what else can we do with collagen expression and the extracellular matrix remodeling to put a little bit more granularity onto cancer-associated fibroblasts. So we looked into single-cell RNA-seq data and were investigating basically, are there any differences in the collagen expression profile from benign fibroblasts, from from pancreas and cancer-associated fibroblasts from pancreas tumors. And we could first of all see that our most abundant collagens were overexpressed in cancer-associated fibroblasts compared to benign tissue, but they were not specific for cancer-associated fibroblasts. But when we looked at some of these other collagens like 5, 8, 11, and 12, there seems to be much more specific, if not completely specific, for cancer-associated fibroblasts compared to the benign tissue. Super interesting days, and maybe we can have some fibroblast-specific biomarkers for tumors here. We took it a step further and looked into fibroblast subtypes. That's what you see over here. And then we could actually see that it was specifically the myofibroblastic cancer-associated fibroblasts that were defined by overexpressing of these tumor-specific collagens 11, 12, and 8. So it's the MyCAFs that contribute to these tumor-specific collagens. We saw it in panc, but we also saw it in lung cancer, and we have seen it in other indications. It's not specific, at least so far, for any specific tumor types. Interestingly, when we look in the circulation of cancer patients and measure these same MyCAF collagen biomarkers, they are highly elevated across indications. And what you see here is the area under the curve, so there's complete separation between cancer patients and healthy reference ranges, and it goes across tumor types. So I just want to focus on type 11 collagen and type 8 collagen for the next couple of slides. So if we start with type 11 collagen, type 11 collagen can be measured similarly to type 3 collagen with a biomarker quantifying the propeptide. So this is a true reflection of the collagen synthesis. Type 11 collagen also have propeptides. And when we measure ProC11, we can actually see here again how elevated it is, but also a very large interpatient variation, allowing us also to stratify patients into high and low biomarker levels. We have in vitro data that also confirms to us that type 11 collagen is being produced by cancer-associated fibroblast and not by benign fibroblasts. We have the prognostic association here also. High levels of ProC11 at baseline gives us patients with worse outcome compared to those with low levels. And similar to ProC3, when we are able to reduce this MyCAF collagen on treatment, that also manifests on better outcome for patients. So bringing down MyCAF activity gives us 60% overall survival at 6 months, whereas that is only 19% if ProC11 is not decreasing. So we can measure these MyCAF biomarkers, and they all seem to be important for cancer. They seem to be specific for MyCAFs, and they provide some prognostic value and are highly elevated in many different solid tumor types. Just double clicking on ProC8. ProC8 is what we have shown highly prognostic in solid tumors. One case here we published in biliary tract cancer and cholangio. Here I'm showing you again that it's independent both from many other risk factors, and it's also correlated both towards outcome in terms of overall survival and progression-free survival. This particular biomarker is interesting because similar to what we have seen with intertrophin and ProC6, type 8 collagen also have signaling capacity in this vastatin fragment that is coming out of the NC1 domain, and we have shown that to be highly elevated in colorectal cancer, for example. I'm bringing this in because a couple of days, if not weeks ago, this paper came out actually linking the functionality of type 8 collagen positive cancer-associated fibroblasts, driving EMT in epithelial cells, linking that to chemotherapy resistance. So here we actually have a link between fibroblast subtypes producing specific collagens and therapy resistance, and we can already quantify that in circulation. So we should probably do more to bring down ProC8 and Col8 positive fibroblasts. Another way around is looking into what types of treatment are actually already being tested that can somehow modulate fibroblast activities. So we have spent some time now in the KRAS space. KRAS is getting a revival. We can see that in mouse model, pancreas tumor-bearing mice, they produce MyCat collagens that can be decreased on treatment with a KRAS inhibitor. And to go full circle, when we look in the TCA database, collagen 6 alpha 3 is the most correlated collagen to KRAS signaling. We have already data showing that PRO-C6 is prognostic for outcome. Can we make a link between CD44 KRAS signaling and outcome for cancer patients with high PRO-C6? Much more work to be done there, but that's where we are. So in the interest of time, this is my final slide, luckily. I just want to wrap up. We have these biomarkers that we can measure clinically to indirectly assess fibroblast activities, and they have the ability to provide some interesting insights and possibility to quantify different fibroblast activities. So yeah, thank you for your attention. I will stop sharing, and I think we have a couple of minutes for questions.
Yeah, we have 10 good minutes for having good discussions. I'm going to ask Diana also back on the stage so we can have some good discussions. I'm going to start with a few here. Nicholas Nima is asking, dear Nicholas, have you ever considered utilizing an anti-fibrotic drug like pirfenidone to overcome fibrosis and target MyCAPs and TGF-beta signaling?
I think that's a really great question, and something we have been thinking about, of course, nintedanib or pirfenidone, which are bringing down some of this fibrotic activity. I think it would be a very nice exploration to evaluate that in the clinical cancer setting. But I think we need to bring in the biomarker angle. I think we need to probably tailor that treatment for those with the high biomarker levels that have the medical need and where we can reduce the burden.
I think if Frederica was, and she's probably still listening in, she would be screaming that she has data from pirfenidone in heart failure that actually showed a reduction in the new sandwich assay. So possibly pirfenidone is actually doing something with PRO-C6. Mads is asking, I think it's both Nicholas and Diana, and I should have been more clear. It would be nice with questions we actually could answer. But do you have data to support a causative effect on fibrogenesis and poor survival? Or is it purely a biomarker related to survival treatment response? It's an evil and good question. I'm going to let you start, Nicholas, then Diana can try as well.
Well, I think for some collagen fragments are biomarkers and some collagen fragments are signaling, and some are both biomarkers and signaling. So endotrophin is probably one example of a statin fragment from type 8 collagen. It's clearly also causing and driving tumor progression. So I think the short answer is both.
Yeah, but I think Mads may be thinking of whether fibroblast is PRO-C3 a surrogate of fibroblast activity, and therefore is it the decrease in activity that is giving us more of fibroblast as such, giving us more increase in survival, or what is it? Is it correlation or is it causality? I think that's what's going, and of course that's a tough question because PRO-C3 may not have many fibroblast proteins do not have causality in them. But I think fibroblast activity is many things. Diana, do you want to add to that discussion? I think it's super important.
I can just quickly add that we actually see an increase in PRO-C3 prior to the detection of a relapse, for example. So maybe there's something that kind of changes before we actually see.
That's a good comment. Good comment.
I don't know if I know the answer. We've also discussed, is the fragment itself related to any of these, progression in disease, which we think it's not. At least for PRO-C3, I can mention this. I think ETP or PRO-C6 is different for endotrophin. So I think, I know in liver, of course, when you look at liver biopsies, you know that the more fibrosis, the higher the level of survival, mortality. That's what I wanted to say. So clearly it's linked, the stage of fibrosis clearly linked to survival. And if you have high fibrogenesis, you will progress further into the to stage of fibrosis. So in that way, I think fibrosis is definitely very important, and I think fibrogenesis for that reason is important. Of course, fibrogenesis is quite dynamic, whereas if you look at stage, that's the result of many different processes. It's not only fibrogenesis; it's also fibrolysis. Again, probably also other aspects. So I think it is a difficult question in that way.
Then there are more good questions. This one is for Amy. I'm gonna let you start, Nicholas, and then Diana can try. These are super good questions. How does fibroblast heterogeneity impact your ProC3 readout? There may be several activated fibroblast types within a tissue. If you start there, Nicholas, then Diana can go on.
Yeah, that was actually why we went to this single cell line-seq data to figure out what is fibroblast subtypes contributing in terms of which collagen biomarker. And I think based on that data, probably collagen is a more generic or universal fibroblast biomarker, where other collagens may be more content specific or subtype specific.
I think maybe I can just then take over a bit. And I think for liver disease, we've not looked at fibroblast heterogeneity and how it affects ProC3. The only thing we've looked at is for example TGF-beta stimulated cells, PDGF stimulated cells, fibrotic cocktail stimulated cells. We actually tend to see that ProC3 is increased in both TGF-beta, and of course fibrotic cocktail is a mix of different interleukins and so forth, or cytokines. We don't see it so much driven by PDGF, so I'm sure there's some differences in fibroblast heterogeneity and how they will produce or affect ProC3 readouts. But I don't have a clear answer in vivo for that. But for in vitro, we do see some differences.
But it's a good question. Thank you for your answers. Then there's a very good question for MASLD or metabolic associated steatotic liver disease with regard to double, single, and mono incretin drugs on GLP-1 receptors. Are there any data suggesting that they have anti-fibrotic effects? Of course, we showed Diana showed some of those data today, that the GLP-1 semaglutide had roughly a 20% effect. We have seen the oxyntomodulin, meaning the GLP-1 and glucagon, had roughly 25 to 28% effect. And additional data out there suggesting that retatrutide has an even bigger effect. Yeah. So it's almost like 1, 2, 3, but this is just one way of looking at it. We have looked at ProC3 and of course other collagens. So I think it's both what is the onset of action and what is the amount of suppression, and we are looking into that. But clearly, for the first drug that was approved of a GLP for fibrotic disease, MASLD, there was a little bit more than 20% decrease. Then Joel is asking if there are other circulating proteins of binding to endotrophin. I'm reading that because I wish I knew, and that's what hopefully the Extracellular Matrix Conference is about. Park has promised he's coming and presenting even more data on endotrophin. Can these biomarkers also be used for brain cancer, glioma cancers, Nicholas?
Yes, we have published a few times in glioblastoma actually, and there's definitely a component there. I think generally probably there's more basement membrane than fibrillar collagen there, but it's something at least to consider when looking more into this.
We've run out of time. Thank you everybody for joining. If you are interested in learning more, there are additional symposiums coming up with fantastic speakers. and of course join the Extracellular Matrix Pharmacology Conference and come to Copenhagen, Denmark, and meet all the ones around the world that are also interested in this. And then, of course, matrix is a central part in many diseases, and we need to change that. Again, thank you for your participation, for chiming in, and see you soon at the Extracellular Matrix Pharmacology event. Have a great evening.
Thank you.